treatment of SE4 equivalent ankle fracture. SE4 equivalent ankle fracture refer to lateral mouth fracture with a deltoid ligament injury. Treatment of SE4 equivalent ankle fracture is controversial. We hypothesize that the SE4 equivalent fracture treated with surgery that's better than those treated with test. To test this hypothesis, a IRB-approved retrospective study was carried out at the Level 1 Trauma Center. This is our inclusion criteria, and this is our exclusion criteria. We divided patients into 3 subgroups. Type 1 is a medial clear space larger than 5 millimeters in straight view only. Type 2 is medial clearance space is 5 to 10 millimeters in regular X-ray. Type 3 is more than 10 millimeters or have a dislocation or synesmosis widening. We abstract data, including prognosis variables, treatment modality, and clinical outcome. Major outcome measurement including functional ankle score and radiological grading. We identified over 1,000 ankle fracture in 5 years period. 84 patients is SE4 equivalent. 43 patients have a functional score. 21 patients have been followed up over 1 year. Age range from 18 to 84 with an average of 42. Similar distribution was found in sex and site of injury. Average follow-up is 21 months. Majority injury is result of a fall, whereas the most common fracture pattern is type 2. And this slide shows the functional outcome in surgery versus non-surgical treatment. As shown in this graph, the cusp actually showing better functional score as compared in surgery group. A similar result was observed in the patient follow-up over 1 year. We group patients as excellent, good, fail, and poor based on ankle score. We found about 50% of the patients in surgery group have a good and excellent ankle score. In contrast, about 77% of the patients in the CAS group have a good, excellent ankle score. And this slide shows the age effect ankle score. We divide patient age into 3 age groups. We found that like a younger patient have better ankle score, whereas the patient over 50 years old had poor result. Similar result was observed in patient over 1 year's follow-up. This slide shows a fracture pattern effect ankle score. Type 1 fracture have the best result. Type 3 have a worst result. Type 2 is intermediate. Since both the age and the fracture pattern affect ankle scores, we wonder if age and the fracture pattern contribute to poor outcome observed in surgery group. And yes, indeed, as you show in the red, in surgery patients are more older and have more type 3 fracture. And since both the age and the fracture pattern contribute to worse outcome observed in surgery group, we then wondering if there's any association between age and the fracture pattern. We found that younger patients have tendency to sustain the group type 1 fracture, whereas older patients have tendency to have type 3 fracture, whereas type 2 fracture have an even distribution in all age groups. We then compare outcome in surgery versus non-surgery within similar setting. And although angle score still exhibit in favor of the cast, however, this difference is not statistically significant. This slide shows radiographic grading. As you can see, the cast group shows at least equally effective to maintain the reduction. And this slide shows the association of radiological funding and functional outcome. Good grading ensure a better ankle score. Interestingly, poor grading not always resulting in the poor ankle score. So in conclusion, SE4 equivalent ankle fracture are a heterogeneous group, can be divided into 3 subtypes. Fracture subtype is important determinant for functional outcome. Type 1 has the best result, and type 3 have a poorest result. A close treatment at least equally effective in management of some type of SE4 equivalent fracture. Older patients tend to sustain unstable type 3 fracture, which was often treated with surgery. This contributes to a poor result observed in the surgery group. And remember, non-surgical treatment is not equal to no treatment. A well-molded cast and diligent observation can achieve equal success. Thank you for your attention.
We have time for a few questions. Is there any question?
Hello,
Please.
I have a question. I'm from China, Beijing. I want to know how you divided the patients into 2 groups. When you give him conservative treatment, and when did you do operation?
Well, we divided. What do you mean? You mean about typing?
Yeah, you have 2 groups. One group for
Well,
cast. Yeah.
This is a retrospective study. So a patient who underwent the surgery belong to the surgery group.
So it's not a randomized control test. Yeah.
It's not a prospective study.
So I think maybe your cast group they have much better injury. How to say? Not severe injury.
Yeah, that's why we sort of try to exclude that the other contributed to different groups. So in one of the slides we show even in a type 2 fracture, which the age and also fracture type is similar in both groups. The surgery is comparable. Surgery result from surgery is still comparable with the non-surgical results. Okay. So suggesting that non-surgery, if it's done well, could achieve similar results as a surgery group.
Okay.
Any more question? Yes, please. Last one, please. Careful.
Careful. So it is said that if the fracture medial malleolus is there and you reduce it even anatomically, even then periosteum is entrapped at the fracture site, so the delayed or non-union may be there, no? So do you suggest conservative management in displaced medial malleolar fractures, even it is reduced nicely?
I didn't understand your question very well. Can you?
I'm talking of the ankle fractures. the two malleolus in the ankle, one is medial, another is lateral.
Yeah.
You got me? So if medial malleolar fracture is there and you have reduced conservatively, it is well reduced, even then periosteum over the bone that interrupted at the fracture sites. What I mean to say, there is no role of conservative treatment as far as I know.
Well, basically, I think we talk here is like an equivalent fracture. I don't think it's not talk about bimaal fracture here. It's like equivalent. You have like a injury of the deltoid ligament, not like a medial mal fracture. And if you're talking about like a bimaal fracture, if you have like an interruption of soft tissue, you have to undergo surgery. So.
Excuse me, I'm a co-author. This study was only on SE4 equivalent fractures, no medial malleolus fracture. So we didn't look at the bimaal fractures in this study.
Okay, thank you for the discussion. Thank you for the lecture.